name is Kelsey, if we haven't met before. I am one of the twos. I'd like to first give a shout out to the Small Talks team. Thank you so much for your help. I'm going to be talking about the use of TXA in trauma, which I know is pretty controversial. So hopefully we'll have some lively discussion at the end. So as a show of hands, how many people here have actually used TXA? Does anyone want to shout out, like, in what context you've used it in? Yeah. Epistasis, epistaxis rather, postpartum hemorrhage. There are a lot of different uses for TXA. We'll focus specifically on trauma today. Brief review of the coagulation cascade. As soon as you have vascular endothelial injury, you have primary hemostasis occur. The first step is the formation of your platelet plug. Secondary hemostasis involves the creation of a fibrin mesh, which reinforces that platelet plug to stop bleeding. On the contrary, fibrinolysis is the breakdown of the fibrin mesh. What happens is you have plasminogen, which is converted to plasmin with TPA. And plasmin will in turn cut the fibrin mesh, and that will disintegrate your clot. TXA comes into play. It's a lysine derivative, and it's used as an anti-fibrinolytic agent. TXA will bind to plasminogen, and that in turn prevents the conversion to plasmin. So if you don't have plasmin circulating around, you are going to theoretically have a stable clot, one that won't break down. I'm sure some of you are familiar with something called trauma-induced coagulopathy, abbreviated TIC. How does our normal coagulation cascade get disrupted with trauma when we have a patient coming in with hemorrhagic shock? So some of the defining features of TIC are this hypocoagulable state as well as a hypercoagulable state. The hypocoagulable state occurs because you have hyperfibrinolysis, platelet dysfunction, fibrinogen depletion, you have decreased thrombin generation, and then you also get this hypercoagulable state, and that's due to increased thrombin, hyperfibrinogenemia, platelet activation, fibrinolysis shutdown. All of this together will cause excessive bleeding and thrombosis. Some people have a mix of both. Some people are predominantly one or the other. All of this is further exacerbated by the diamond of death. I'm sure people have probably heard of something called the lethal triad of trauma. Now people are tending to use this diamond of death to describe what happens in the coagulation cascade. And this is the difference between the lethal triangle and the diamond is that now we consider hypocalcemia to be exacerbating the coagulopathy that you get. With blood loss and transfusion of blood products without calcium, you have further hypocalcemia. You also will have hypothermia because you're losing a lot of blood, you're not perfusing well, and that's going to decrease the metabolism of citrate, so there's going to be more bound calcium. Without available ionized calcium, you're going to have more of a coagulopathy. And then you also see acidosis from hypoxia and decreased ionized calcium. It should say acidosis at the top, it's just covered. So studies have shown that in trauma-induced coagulopathy, there's an early and late stage. The early stage is typically characterized by bleeding and tissue damage. The late stage is typically thrombosis and organ failure. So when do we actually use TXA? It's an antifibrinolytic agent, and it's preventing the breakdown of clots. So if we want to increase clot formation and clot stabilization, ideally you use it early in trauma to prevent this early trauma-induced coagulopathy. There have been many, many studies on the use of TXA in trauma, and two of the landmark studies, which are also blocked at the top, CRASH-2 and CRASH-3, I'm going to briefly go into. But I'm also going to present the most recent trial that was published, Patch Trauma, this past summer. CRASH-2 was published in 2010. I know a lot of you are familiar with this landmark study. Just a brief overview. This was a double-blinded RCT. And back in the early 2000s, they recruited over 20,000 patients with traumatic hemorrhage. They defined this as a systolic blood pressure that was less than 100 and a heart rate that was over 100. or if they were at risk of significant hemorrhage within 8 hours of injury. Patients were excluded if they had a clear indication for TXA or a clear contraindication for TXA. Most notably, they left out patients with intracranial hemorrhage. So what they did is they used 1 gram of TXA over 10 minutes and an IV drip of TXA over 8 hours. They found a statistically significant decrease in all-cause mortality at 4 weeks and a decrease in the risk of same-day death that was due to bleeding. There was no statistical difference in the risk of vaso-occlusive events. So think about TXA, if it's antifibrinolytic, you're concerned about maybe this like procoagulant state. But this study didn't show that there was any increased risk of DVT, PE, MI, et cetera. They also didn't show any difference in the reduction of transfusion requirements of using TXA versus placebo. What they did find is that if you use TXA after 3 hours, there was a statistically significant increased risk of death. From this study, the absolute risk reduction was 1.5%, which seems like a pretty small number, but on a global scale, it was enough to make the WHO decide to include TXA as one of the essential, one of their 2011 list of essential medications. The number needed to treat was 67. And some of the critique of this study was that there was no stratification of injury severity. Also, the follow-up was only 28 days, and as we know, traumatic injuries can have lifetime effects. And finally, they didn't include TBI patients. So we couldn't really make a conclusion. And that prompted the initiation of the CRASH-3 trial. CRASH-3 was published in 2019. The most common cause of death, actually, of the patients that were enrolled in CRASH-2 was traumatic brain injury. So with CRASH-3, they did a double-blinded RCT. And they asked the question, does TXA reduce death from traumatic brain injury? They recruited over 12,000 patients with traumatic brain injury. And this was defined as GCS less than 13 or intracranial hemorrhage as seen on CT. Patients were excluded if they had major extracranial bleeding or their GCS was 3. And what they found was that using TXA versus placebo, there was a statistically significant decreased risk of death for patients with mild to moderate TBI. And I know that this conclusion was controversial. They also found that there was no statistical significant difference in the risk of death within 3 hours, the risk of death with severe TBI, and again, this was another study showing that there was no statistically significant increased risk of these vaso-occlusive events, which is the fear with TXA use. So some smart people analyzed the study, and the major conclusion that they drew from it was that it's reasonable to try TXA for patients with traumatic brain injury if you have a GCS between 9 and 15. However, there was need for more evidence. And here you can see kind of like the Goldilocks effect, like if it's not a severe brain injury, you don't need to give it. If it's mild, you can consider its use. And if it's severe, it's probably not going to help these patients. They're going to do poor regardless. So Dr. Z's website, the NNT, reviewed this study, and they gave TXA a big red flag for traumatic brain injury. So they argue that there's no survival or disability benefit for the use of TXA for traumatic brain injury patients. And that's for many reasons that I'm not going to go into in too much depth. But I know that Dr. Piccioni is leading a trauma critical care journal club next week, so you can go to that. One of the main considerations why it wasn't shown to work is because they changed the protocol like halfway through and changed the primary endpoint. So people believe that they skewed the data. And then finally, this past summer, there was the publication of the PATCH trauma trial. This is hot off the press. And their question was, does pre-hospital TXA increase survival with a favorable functional outcome at 6 months? One of the critiques of CRASH-2 was that it was performed in an under-resourced environment. And where we work, like in an advanced trauma system, there are questions about whether this is really applicable. So they recruited 1,300 patients that were at risk for trauma-induced coagulopathy. They included TBI patients. And they decided whether they were at risk based on the COAST score. COAST score is a validated measure of risk of trauma-induced coagulopathy based on these criteria here. And they found that using pre-hospital TXA. So this is before the patient actually comes to the hospital. The paramedic or the physician decided to give the first gram of TXA and then IV infuse it once they came in. They found a statistically significant reduction in mortality at 24 hours and at 28 days. So that's a pretty short time period from when that patient first presents. They also found no significant differences in good functional outcome at 6 months, which, as you remember, is the primary outcome for this study. Once again, showing no increased risk of vaso-occlusive events. So how are people receiving this new study? Some of the critiques that I've seen is, or rather some of the concerns that I've seen are that there's no difference in favorable functional outcome at 6 months. So why are we really using it if 6 months down the line, patients are equally disabled as when they first came in? They also found no difference in 6 month mortality. Again, same question. 35% of the patients had a protocol violation, so something to consider when analyzing the results. There was potential for selection bias depending on who got TXA. And people do think that maybe this is more evidence that TXA should be given within 3 hours to reduce short-term mortality. And that begs the question, in a place like King County, where the injury to hospital time is usually pretty quick, is it practical for us to be incorporating TXA pre-hospital, or is this more something for like military and rural areas? So I'll bring this question up at the end here. What I think is that based on these 3 huge studies, we're not seeing any statistically significant increased risk of vaso-occlusive events. So this theoretical risk of DVT, PE, MI, stroke, it's not really shown to happen in the literature. It's more of a theoretical risk. We're also seeing this short-term risk of death in the immediate term. Some trauma specialists argue that that immediate reduction in mortality is going to be more important for traumatic hemorrhage and traumatic injuries compared to a long-term, like 6 months reduction. So in my opinion, if you're able to give TXA within 3 hours, which we usually are able to, I would say why not? In summary, early use of TXA is better. Don't give if it's over 3 hours. TXA doesn't appear to increase vaso-occlusive events. Consider its use for mild to moderate TBI. Again, arguable, controversial. The dose is 1 gram bolus and then an IV infusion. And now with the patch trauma trial, we can consider this pre-hospital use of TXA, including it in EMS. There are short-term benefits, but the long-term benefits are not clear. These are my references. And I'd like to ask if there's any questions, thoughts,